And I want to welcome you to this year, which recognizes the 28th year of the Leadership and Faculty Development Program in our conference here at Harvard Medical School, and more than 20 years of our Minority Health Policy annual meeting. And today's topic, I'm happy to say, is about maternal fetal health. And it's a part of our Equity and Social Justice series here at the medical school, an opportunity to talk and learn about a very important topic. This series, this Equity and Social Justice series, includes lectures, dialogues, forums for members of our Harvard Medical School, our affiliated hospitals, our Longwood, and our greater Boston community. And it provides a context to the historical, current, and future states of equity and social justice in health and healthcare. And it engages and equips participants with tools around four major areas: history and context, culture and environment, disparities, and the fourth is leadership and skill development. So within this past year, under the leadership of Alden Landry, as well as from really guidance, assistance, help, holding everything up from members of my office, we've had programs on American Indian health policy, Asian American health, Black men in medicine, Black women in medicine, a documentary, Latino Health Forum, precision medicine, the public health charge, and a Veterans Day ceremony. So today, I'm sure it's not going to be informative, but it's also going to raise some challenges around maternal health and also hopefully provide us some insights around interventions and solutions to those challenges. It's good to know what the problems lie, but it's even better to know what to do about them. Today's program is being led by Dr. Alden Landry, who's an assistant professor in emergency medicine at Beth Israel Deaconess Medical Center. He's an assistant dean in our Office for Diversity, Inclusion, Community Partnership, and he's an associate director and advisor in the Castle Society at Harvard Medical School. He's also now the director of health equity education for the medical school. And like everything at Harvard, he's also the senior faculty in the Disparities Solutions Center and a founder and co-director of a nonprofit organization, Motivating Pathways. Many of you may also know of him in his role in leading the Tour for Diversity in Medicine, which is an effort to increase the number of underrepresented minorities in medicine, dentistry, and other biomedical careers. He's been recognized by his peers. He's received many, many awards. I was last at the Health Quality Forum, so I could see him in his leadership role there, and I could be adequately impressed because he did such a good job. He's a graduate of Prairie View and University of Alabama in medicine, emergency medicine at Beth Israel. He did a Commonwealth Fund Fellowship here and has an MPH from the Harvard School of Public Health. And with that, Dr. Alden Landry.
Good afternoon, everyone.
Good afternoon.
See, Joan knows the call and response. I won't make y'all repeat because I know she usually does it anyways. But I want to say thank you all for coming to another one of our Equity and Social Justice lecture series. As Dr. Reed mentioned, we've had a number of these topics over the year and really over the past 3 years. And we've really tried to listen to what's happening in our country, what's happening locally, what some of the concerns are from our students and our faculty, and then also things that we think are important that just are under-discussed in medical education overall. And that's how we've come up with our topics for these issues. And I'm very proud of the topics that we've hosted so far this year, talking about Latino health and talking about Asian American health and talking about intersectionality when it comes to different groups and how they may be experiencing our healthcare system and the negative effects that they may experience based off of their race, their ethnicity, their country of origin, or whatever it may be. These topics are continuing to evolve, and we look forward to having more of these discussions just to broaden the discussion around medical education and practice here in the Harvard community. But we also want to make sure that we're embracing the Boston community and the state and the region. And if you look at many of our topics and many of our speakers today, they're not just coming from our institution, but we looked outside to hear what's happening in our communities and how others are leading these conversations and helping us to drive forward around these discussions around health equity. Our topic today around maternal fetal health was something that was really generated, again, from our faculty and from current and past fellows as we talked about some of the issues relating to health disparities and outcomes when it comes to maternal fetal health. And I would say right now there's a lot of political will that's sort of being generated. Numerous candidates on the Democratic side have introduced bills and legislation or are having discussions around outcomes and health disparities and black-white differences that we're seeing with maternal fetal health. There's been a bill released both on the Senate side and in the House of Representatives side about addressing health disparities. So there's definitely the political will to have this discussion and to make the changes necessary. But I think this conference that we're having today is really about what interventions are being done, because we know that the disparities exist. So what interventions are being done and what opportunities are there for us to be leaders as we try and address the changes that are so necessary. I'm really excited about today. I'm excited to learn and hear from our panelists. I think we have a great group of speakers that are going to be joining us. But first I want to introduce our keynote speaker. His bio is in the handout that you have, so I won't read it for the interest of time. But our keynote speaker is Dr. Eugene Declercq. He's a professor of Community Health Services and Assistant Dean of the Doctoral Education at Boston University School of Public Health. And he's a professor of Obstetrics and Gynecology also at Boston University School of Medicine. And when I asked Dr. Declercq about why he's so interested about this topic and what brought him to the research that he does, he mentioned about his own children being born and the experiences that they had, and then also the importance of students asking questions and asking the why. And that's really led him to dive more and more into this topic and think about this on a deeper and more rich level. So with that, Dr. Declercq, the podium is yours.
Thank you. It's a delight to be here, and it's an honor to be here. What Alden didn't mention is when he asked about that, I said, after the birth of my children, I decided to become a childbirth educator, taught Lamaze classes, only male in the country at the time, a little strange to be sure. And it was in those classes that it generated the work that I do now, because couples would ask questions and I didn't have answers. Over and over again I didn't have it. Pretty much like my regular teaching, but more pertinent to them and more immediately important to them. And that's what started it. One question after another, and you sort of get sucked into this issue, and I can't imagine an issue that's more compelling to deal with than childbirth, given the ramifications of it in terms of the long-term impacts on the lifespan, and as a researcher, the variation in questions you have to ask. You know, to study this, you have to be not just an obstetrician or a midwife. You have to be a sociologist and an anthropologist and an economist and a policy analyst if you really want to understand that. And that's before we get to health services research, right? So all of those things have to be understood to see where we're going to make change. Now, what I'm going to talk about today is maternal mortality. And let me get into it, because I have till 4 o'clock this afternoon, I'm told, right? I can just keep going. As some people here know, I could keep going till 4 o'clock, but and I'll have hundreds of slides for that, but I won't. Let me first acknowledge my colleagues in this, that all my research is a function of collaborations, and these are all the people I've published with over the course of my career, and some of them are in this room. And I think if we're going to solve problems, if we're going to address problems effectively, it's only through collaborations. And I'll note, about 20 of these people are obstetricians, and about 20 are midwives. And I think we have to keep moving across lines and listening to each other and valuing the different questions that colleagues from different backgrounds ask if we're going to try to address these difficulties. And so everything I say that you find controversial or questionable, it came from them. Things you find pithy and interesting, that's just me. Okay, simplest outline you'll ever see, right? I posed 2 questions. We're going to deal with those. Why is maternal mortality worse than you think it is, and why is it better than you think it is right now? But first, we have to clarify some definitions, because there's a lot of things that get thrown around talking about maternal mortality, and there's different definitions, and they have different meanings for us. So these are the 3 official definitions that get used. Pregnancy-associated deaths is a time-bound figure. It only means the death of a woman for any reason between pregnancy and a year after pregnancy, right? She can be hit by lightning. It is essentially the denominator, the starting point for analyses around this. I'm on the Maternal Mortality Review Committee, and there's several members of that here too. And that's our starting point, right? The first question you have is the state pulls up all of the deaths that could be relevant to you, right? And then the first determination is this pregnancy related or not? I'm going to argue that it's critically important that maternal mortality review committees spend a fair amount of time on just pregnancy-associated deaths that are not pregnancy-related, because I'm going to make the argument that we have a crisis arising not just in maternal mortality, but in death rates of women in general. And as a result of that, the place that gets looked at in any depth right now are maternal mortality review committees. Now, they may be doing it as the screening point to which they have to get to pregnancy-related ones, but this is really a critical area that needs additional attention. Then the differences between the next two are the differences between the United States and the rest of the world, essentially. Because the definitions are similar, but they involve different time frames. So the maternal mortality ratio, death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of duration of the pregnancy, from any cause related to or aggravated by the pregnancy. Pregnancy-related mortality ratio is essentially the same definition, only it's extended out to a year. And the difference is WHO relies most heavily on the maternal mortality ratio. The CDC publishes the pregnancy-related mortality ratio. And the reason that has any importance at all is simply the fact that it's become a hindrance in comparing the United States to the rest of the world, that we don't conform to the way the rest of the world does that. Now, how we got to that point will be the subject at the beginning of this, and the beginning of why this is maybe worse than we think. This is the timeline. I think it's straightforward enough. The blue line and the green line represent the pregnancy-related and the pregnancy-associated. Again, they both go from 21 months, right, from the initiation of pregnancy, assuming a full gestation, out to a year afterwards. In the case of WHO's, beginning of pregnancy out to 42 days. And this is data from Massachusetts that shows the rates of the two, of pregnancy-associated and maternal mortality. And in a sense, we never think of it that way, but the gap that you see between them is the area I've become increasingly interested in. The non-maternal mortality cases that still result in deaths of young women, right, that we need to be paying additional attention to. When the gap is small, that means almost all of the cases are pregnancy-related. So, why is it worse? The U.S. has a problem, and we don't even know how bad it is. And that's pretty bad for a highly developed country, a wealthy country like our own, to deal with. How does that happen? Well, this is the data we do have, going back to the 1950s, and you see it in three periods. In this first period, from the 50s to the early 80s, a substantial decline, an 89% decline in the maternal mortality ratio in the United States. Very heartening, very positive. But then we get through the period of the 80s and 90s, and it's pretty much flat. There's almost no change whatsoever through that period. Then we get the period from 97 to 2007, and it's actually going up, which is not what we expect with mortality ratios. Right? The assumption is the mortality rates or ratios, depending on which measure it is, we expect them to continually go down because we're the United States. There's more money available. People should be healthier. There's no reason to expect rates like this should be going up at any point. The other thing that's a bit curious here, of course, is why the hell does it stop in 2007? Right? What happens there that we stop presenting a maternal mortality ratio for the country? And it's a classic example. Depending on the audience I'm talking to, some people see it as sort of a conspiracy that, because we were doing poorly, they didn't want to put it out anymore, so that would, no. First rule of thumb is always, before you think conspiracy, think bureaucratic ineptitude. And in this case, it's good intentions gone wrong, as you'll see. Nobody's trying to hide anything. They were actually trying to improve the measure, and in the process of trying to improve the measure, it raised all kinds of other problems. It's also the impetus for me being involved in this. I've been giving talks on this for 20 years. And one of the things I do is compare the United States to other industrialized countries. And this is one of the charts I would always show. And I do this with neonatal mortality and perinatal mortality and such. And when I went to do it with maternal mortality, it looks kind of silly that the other countries continue produce data, and we're sort of sitting there for the last decade with nothing available. So that got me interested in dealing with the question. And this is the last actual official report. This is from the last time they actually reported a maternal mortality ratio. It's a 2007 death report. And there's that 12.7 that you see at that point. And they haven't reported one since. I was in a meeting in DC last week where the person responsible for death reporting overall said that they've resolved some of their problems and they anticipate they'll report a 2018 rate, which of course will happen in 2021 because it always takes several years. You know, we still have the most recent data we have right now is 2016. And so it is coming back. Now, this great mystery of what happened in the interim. Well, this is what happened. They wanted to improve case ascertainment. The idea was, how can we improve case ascertainment? And the fear was that they were missing cases during pregnancy. They were missing deaths that occurred during pregnancy. And the attempts to improve case ascertainment actually led to over-ascertainment and then concerns about the measure again. So for those of you who don't do vital statistics for a living, and I'm shocked that you don't because it's so exciting, but about every 13 or 14 years, they do a revision, right? We don't have national data. We truly don't have national data. We have state data that gets sent to the national and put together at the national level that way. But the feds don't control all of that. What we do have is agreements between the states. And the states will agree that of the birth data that we collect, of the death data that we collect, of the fetal death data that we collect, we will agree across the country to send these variables to the National Center for Health Statistics, National Vital Statistics Branch, who will then compile a national figure from all of that. And as you might imagine, as we progress, our knowledge progresses, science progresses, we want to improve that, right? And because there's like new variables that may come up, new issues that may come up that we want to understand better. And so roughly every 13 years, in 1975, in 1989, in 2003, they have national consensus efforts to try to figure out which variables are we going to use. Are we going to ask all states to agree to send in? So it was at this time they decided they were trying to improve the measure of maternal mortality through this. This is a pregnancy checkbox. It's that tiny little box that you can't possibly read. But this is what it looks like. And it basically says, I'll just go back for a second, it says if the female was decedent pregnant at the time of death or within the past year, then that's part of that checkbox. And the actual checkbox reads this way. If female and of reproductive age, which is defined very, very broadly, I want to be inclusive here, if female, not pregnant within the last year, so the death certifier is supposed to do a review and check the box or not check, or check the appropriate box in this. So that was the idea of how can we pick up those cases during pregnancy, because their fear was they were losing that. Now there's a whole history of this. This doesn't just happen. In the 90s, early 2000s, they're looking at this question. Other countries are using something like the checkbox as well. So we're trying to improve this. But one of the difficulty was 16 states already had something like this, but they had widely varying measures of it. This is just something, these are examples of states that had it. They used time periods like out to 42 days. Others use the language out to 6 weeks, out to 3 months, out to 90 days, out to 12 months in the last year. So part of the effort was to standardize that measurement. So we'd have the same measure across all the states. Standard epi data geek stuff, right? The other was, well, what about the 35 states or so that didn't have anything? They will now do it. Now we'll have a standard measure. This is going to be great. This is going to work out, right? Every time they do this revision, I've been involved with this a long time. I've been through the 89 and 2003 revisions. Every time they do it, it's going to be great because we're going to get all this new information that we can then use on a population basis, right? That's what's so exciting, is having this for the entire country as a data tool that we can use to make better clinical decisions and make better policy decisions. Well, slight problem. When they make the changes in 75 and they make the change in 89, the states agree. What that essentially means is they print a new form, right? They print a new form that the states have to fill out. They have to do training to make sure people appropriately fill out the forms, but it's printing a new form. And then the forms get submitted to the feds, and somebody has to compile all of that. By 2003, we're in a different world, right? By 2003, it's electronic systems which means reprogramming systems, which is a lot more expensive than printing a new form and doing training. So the states go to the feds and say, fine, will you give us money to do the reprogramming necessary? And the people at NCHS say, sure, absolutely we will, and then they don't. And so the states respond very maturely by saying, oh, well, the heck with you then. We're not going to do it. And some do it and some don't. And what this represents is the accretion of states over time in doing it. And you can see it's adding through. Starts off with 4 states that agree to do it, to add the checkbox, another 7, another 7, another 4. And by 2007, they're essentially at a form of equipoise. Almost half the states are doing it and half the states aren't doing it. And the problem that that raises is all of the preliminary work, and actually the work even before they added the checkbox showed states with the checkbox were reporting higher rates than the states without. So now the people at National Vital Statistics System are worried because they don't feel like they have a national data system. They have half the states doing one thing, reporting higher rates, and the other half of the states reporting by the old system with lower rates. And you can't just combine all of that. And so that's when they stop reporting. And that's why they're going to start reporting again in the next 2 years, because they think they've at least resolved the issue. By 2017, all the states will have added the checkbox. We'll see. Other problems arose as a result of that. Just to be a little parochial about this and brag a little bit about it, it's nice to know that at least in Massachusetts, we were the last state in New England to have actually made the change. And when we made the change, we not only made the change late, we did it in the middle of a year, which further complicates the attempts at trying to do this. But to give credit where it's due, we did the same thing with the birth certificate. That change was 2003. We didn't make that change until 2011, and we did it in like February 20th of 2011. So you almost lose that data year because you have these mixed systems going on, right? When I talk to audiences from New England, they love that. All the people not from Massachusetts love to see Massachusetts do something worse than they do, because we always look down at other states. The only state that looks down more is the state of California, and damn it, they did it in 2003, so they ride on this quite directly. Now, that led to the analysis. So I contacted my colleague, Marion McDormand. She's the one I do most of the work with over the years. And she was at National Center for Health Statistics for a couple of decades. And I said, can't we figure this out? If we go and use state data and model the state data, couldn't we come up with a national estimate? If we spent some time and really thoughtfully did this, maybe we could come up with a national estimate we could use to then once again compare the United States to other countries. That was our goal. And that resulted in this article that came out now almost 3 years ago. Do we come up with sexy titles or what? Disentangling trends from measurement issues. I mean, there's a grabber. It's going to get a lot of attention from the media. Turns out this got tons of attention from the media. And the reason it did was that little underlined piece. So when we do the analysis, what we do is we model what's the effect of adding the checkbox on a state's rate. And then from that model, it was a pretty simple model, but from that modeling, we come up with a trend number for the state and then combine all of the states. But when we did this, we had two states that were problematic. One was California, because California wouldn't report its data out to 42 days. They only reported it out to a year. You couldn't break it out, so we couldn't use California in trying to do a national maternal mortality rate, which goes to 42 days. There was no way to separate that out. Big loss, 480,000 births in California, right? The second biggest state is Texas, and we decided not to use Texas for a different reason. In Texas, so what we find is when a state adds the checkbox, the correction factor is about 1.9, almost doubles their maternal mortality ratio. So huge impact from that, right? In Texas, they added the checkbox in 2006. It makes almost no difference in their rate. But then between 2010 and 2012, their rate, which was already high at about 18, doubles to 37 and stays up at that 37 rate. And our analysis of it was, it's a data problem. This is not, Marion had a wonderful line in there or something, short of a catastrophic weather event or war, you would never see this. This just doesn't have, double. that you would double in Vermont because nobody actually lives in Vermont, so there's no births there. But Texas has 300,000 births a year, so that's a pretty stable rate, right? The two most stable rates would be in California and Texas because of their size. And so we said we're not going to include Texas in the national estimate, right? For data reasons, not anything else. But what we didn't anticipate was there had been an article published in New England Journal shortly before that looked at the closing of Planned Parenthood clinics in Texas and argued about the loss of services, right? So what happens is this. This is the biggest, I've been doing this stuff for 40 years. This is the biggest media coverage we've ever had on anything we've ever done in this. Why? Because two things, I think. One, CDC had been putting out a pregnancy-related mortality rate for years, and no one was paying attention to it. Everything we talked about in terms of an increase had been reported. It was there on the CDC website for a decade and a half. But the term pregnancy-related mortality just didn't resonate with people. Once we call it maternal mortality, and we did that simply because we wanted to do the international comparison, that seemed to resonate. People seemed to pay attention to it far more than it had in the past. But the other piece was that Texas finding. Here's the quote. You wouldn't expect that kind of a jump. That's the jump we saw between 2010 and 2012. So what happens? This gets reported. People jump on the, media likes to jump on the big find, and they report the Texas finding. And we're doing interviews saying, all we're saying is the data is they probably have a really serious data problem there in Texas. But this first gets picked up in Texas. Whole series of articles in Texas about us. Our rates are doubling. There's a crisis. Interestingly, Mary and I were just at this meeting last week, and somebody from Texas came up and said, thank you for publishing that. We said, we just said your data was bad. She said, yeah, but that got everybody talking in Texas, and they were about to close their Maternal Mortality Review Committee, and they sustained just barely, by the way, but they sustained their review committee, partly as a result of concern about the rate, even though, remember, all we're saying is you got really bad data there you got to worry about. Right? So this comes out in Texas. Then it gets picked up but in conjunction with the New England Journal article, and the national media picks up on it because it fills a sort of liberal bias, right? What's that? Dumping on Texas. And so there's all these articles linking the closing of Planned Parenthood to this. New York Times does 3 different articles on it. An op-ed, Paul Krugman does an op-ed on it, the whole thing. It's a story after story after story on it. What does that do? That justifies the rest of the media jumping on it, right? Once the Times does it, everybody else jumps on. So you've got all of these. Note the quote at the bottom. That's pretty much what they would always say, right? While the authors would not say that there was a direct relationship between the cuts and the rise, and then they would just go off and say it was because of the cuts, right? I mean, look at Krugman's article, States of Cruelty. They're implying direct links between the closing. We're not saying it didn't happen. We're not saying it did happen. Our data was certainly not granular enough to let us do that at all, and we never said that in all of this. But of course, in the times we live now, what does this result in? We get attacked in Texas. And a fact check says they were wrong saying this was it. We never said that, right? That never happened. I like the one up above. Pro-abortion activists hiding behind the often undeserved cloak of credibility provided by peer-reviewed journal made a concerted effort to mess with Texas. No, we didn't. I like Texas. Okay, I don't like it that much, but I like it. And we had no reason to go through all of that. And that's one of the challenges now, right? Everything is politicized. I mean, the Green Journal published a letter to the editor about our article. If you look at the journal, what the Green Journal says is it has to be published, I think it has to be submitted within like 60 days or 90 days of the publication of the piece. It can't be more than 500 words. This was submitted a year and a half afterwards. It was 2,000 words, and it was a think tank, a conservative think tank in Texas that was funded to do this whole reanalysis. We did a big response to it. But again, this is like fighting over stuff we shouldn't be fighting over. What we said was there's bad data. So then Texas went and did a study, and what they proved was they had bad data, that there was all kinds of misclassification. Why? Part of it is the question becomes, well, who's certifying all of these things, right? I mean, maybe in the mass public there's an assumption that certification of death is like by autopsy, right? Because they see that on TV, and it's right. 8% of the cases get an autopsy. Right? So, is it a physician? Probably. Is it a medical examiner? Maybe. In Texas, it can be a justice of the peace who certifies the death. So, when you have a system that's that loose, you're going to have problems in your data. That shouldn't be a shock to anybody. So, back to our findings. So did we create a more accurate representation of state ratios, or did we have an overestimation? And our feeling is, despite we really worked hard in the article, at the end of the day, it was an overestimation. So then we went back to the question of the quality of the data and started looking at that. Luckily, a separate source of information now is the Maternal Mortality Review Committees. And CDC has invested a great deal amount of money, mostly from Merck, funding them, the Merck Foundation funding them to do this, to do studies with maternal mortality review committees. And this was just published a couple months ago. A 4-state study from maternal mortality review committees of the accuracy of the checkbox. And what this simply shows is in 72% of the cases, the woman was pregnant. In 21% of the cases where the checkbox was checked, mother wasn't pregnant, woman wasn't pregnant. In 7%, there was no way to determine if the woman was pregnant. So, we probably have some over-ascertainment here, right? There's a problem. Now you're saying, really, how could that happen that often? What's interesting is we modeled what would random error do here. What if there was a 1% random error in the checkbox? Simply because people are rushed, they're doing it. And the deal is this. Once you put the check mark in that checkbox, it becomes a maternal death, right? It trumps every other code that you have. Right. So when you model that, it turns out that it kind of fits what's happening, that you're going to have numbers like this if you just had random error in doing it. So the other thing that you find, and this is because of that rule about if the box is checked, it has to be a maternal death, a big increase in codes for less precise reasons. So, this is ICD-10 codes, ICD-9, ICD-10 codes, depending on timing. And there's a whole array of codes associated with death, right? There's a whole cluster in the same area. But 4 of them are these, 4 of the old codes are these. Other specified pregnancy-related conditions, other obstetric complications, other specified diseases and conditions, other obstetric death of unspecified cause. And what we found was most of the jump in the mortality rates were coming from the other codes, which you can imagine if there's a mistake made on checking the box, someone then has to put something in there, and it's going to be one of the mushier codes. Now, before you feel too comfortable about this and thinking, well, then we're doing fine, sorry. If you limit the analysis to just the really specific codes, our rate's still going up. So it doesn't get us off the hook. This is why I say this is why we should be feeling worse. We're both, by accurate accounting, doing worse, and we don't know exactly how much worse we're doing in all of this. My grandmother always said, life isn't simple. The other side of this is, before we throw out the checkbox, this was from another study using careful reviews. And what they found was, without the pregnancy checkbox, roughly 50% of the pregnancy-related deaths that occurred during pregnancy, 11% of the deaths that occurred within 42 days at the end of pregnancy, and 8% of those that occurred between 43 days and a year would not have been identified. So what you get is a classic result when we try to adjust measures. We improve it on one side, we hinder things on the other side. That's how measurement evolves, right? The key is to be transparent about what you're doing, to get in there and try to fix it as soon as you can, and that's what started to happen in all of this. Now, there has been a way we can monitor maternal mortality over time, and that's CDC. And so while we have this whole national vital statistics system that seems to be failing us, CDC is sort of chugging away with their own entirely separate system called the Pregnancy-Related Mortality System. And you go to the website, let me summarize this. So if we take the vital statistics system out, because it's not producing anything for us now. They're working at it, but nothing is happening. We have 2 sources of reliable data on maternal mortality. And the most reliable one is the Pregnancy Mortality Surveillance System at CDC. This is the definition of it. I'm not going to go through and read it, but basically it involves states sending them their data. It has the added advantage that they ask the states to link the death data to the birth certificate, which gives them a number of other variables that they can use. They also do positive case identification. There's somebody at CDC who goes through newspaper reports of deaths to try to identify more cases. So they put all of that together. That's the good news. The downside is it's CDC's data. This is not a public data set. This is controlled by CDC. They don't share it. They don't always play well with others with their data, right? It's their data. So we're sort of beholden to them on when it comes out. It comes out when it comes out. It's not part of the regular reporting system. Thoughtlessly, it came out yesterday after I had already done all my slides. And so I redid my slides, the slides I'm going to present you in a minute, last night to incorporate the new data that they presented, probably for Mother's Day. My guess is not to screw me up, although I'm wondering about that. But I think it's probably for Mother's Day because they got a big hit. It was New York Times front page today. The third one is this maternal mortality review information application, the tortured Maria acronym. That's the reporting. So they now have set up a system where they're asking the states that have maternal mortality review committees to agree to a common set of variables that they'll report to the central site at CDC. And a lot of the states, Massachusetts is one of them, have participated in that system and are continuing to participate in that system. And the hope is that's going to be much more finely tuned data because it's going to be the result of the careful examinations at the review committees. That's great. It's going to be slower because now you have that extra layer, right? It takes us a while. We're still reviewing 2016 cases in Massachusetts. So it takes a while for all of this to catch up. But it will likely give us variables we wouldn't get any other way. So this is the PMSS system. This is the report that literally came out yesterday from them, updating their data. And this is that definition again. So these are the trends, using, I think, our best existing measure. And what you see is, this isn't subject to the check, well, pretty much not subject to the checkbox. What you see is a consistent and profound rise in the pregnancy-related mortality rate. Now, again, remember, this goes out to a year, so the maternal mortality rate would be slightly lower than that. The other thing they did with this that's really helpful is this. They started reporting on the timing of deaths, which was great. We've been writing them to say, you know, this is the way to get at policymakers, is to talk about timing, right? Not just this glom of deaths, because you're talking about a 21-month period, and a death in the second month of pregnancy versus a death 8 months after the baby is born is a very different event. And for the first time in their annual article, the one reference there, they reported it. And then in this new report that came out yesterday, they went into it very deeply, which is great. That's a bit of a game changer for the discussion around this. A couple things to note here. Maternal mortality ain't Downton Abbey. It isn't somebody dying during the middle of labor, right? That accounts for some of these. It accounts for 17%. And if you want to say it lingers on for, you know, a condition may linger and cause, you're talking about a third of the cases are at the time of birth, right at the time of birth. A third of the cases are during pregnancy, and a third are between 7 days and a year later. This revises our whole consideration of maternal mortality, I think. It should, because it means it's not just a clinical problem. What's circled there is the clinical issue, right? Clearly clinical issue. And what we've seen, and I'll get to in a moment, is a strong clinical response. The clinical community is doing a great job of trying to deal with this. But this is a public health challenge as well. It's a massive public health challenge that we have to address. And the other piece is, by the way, just a side geeky data note, if you have this data and you know the timing and you know that 11.7% of the deaths were between 42 days and a year, take their data, take out the 11.7%, and you have the maternal mortality ratio, right? This is just simple logic. So I asked the people at CDC, I said, so if I report that, because I want to report an accurate data, I said, what if I report that? What if I start using that as a rough estimate? I'm not saying it's precise, it's a rough estimate. Can I do that, and would you be comfortable with it? And they basically said, we can't tell you to do that because it's not necessarily appropriate for you to do that. And so I started doing it because that gives us, this is the best data system we have, and we can adjust it accordingly. Not perfect, but an adjustment. So if you do that, this is the maternal mortality ratio. It just brings all those numbers down slightly. But now we can compare it to other countries, right? They also reported, and this is the old data. I'm going to give you newer data on disparities. That's from the previous one. I realize I didn't get all the slides. If that earlier slide I used where I said I couldn't report anything, now I can using that. And it's a depressing story, right? That we start out worse than other countries, comparable industrialized countries, and we go up and they go down. And so the difference between ourselves and similar countries, wealthy countries with a large number of births, for reliable comparison, the differences are getting greater, not smaller, over time. What about racial disparities? This is from the new data. These are the rates they reported yesterday, ratios they reported yesterday. For Hispanics, 11.4 per 100,000. Whites, 13 per 100,000. Asian Pacific Islander, 14.2. American Indian, Alaskan Native, 32.5. Black non-Hispanic, 42.8. Stunning differences by race, ethnicity. The other nice thing, and I suspect the reason they use 5 years is this is the first time I've seen them reported for indigenous people as well. And those rates are appalling as well. Now, these are the rates over time, back when we reported. And this only has black, white, because when you go further back, they weren't recording Hispanic, and they couldn't do that refinement. And what you see is that looks like the disparities are decreasing a lot. They're actually not when you think of it as disparities, because the base number for the whites is going down. So you're saying, could you give us a chart that just looked at disparities? Sure, here it is. This is the black-white disparity over time, and it's consistently between 3 and 4 times higher for black mothers than it is for white mothers. I think that's important, and I think you see how striking it is when you put it in this context. This is the black-white disparity for maternal mortality. This is the black-white disparity for infant mortality. There's nothing to brag about with the disparity on infant mortality. It's disgusting. It's 2.5 times higher for black infants than it is for white infants. But it is consistently and profoundly higher in the case of maternal mortality than it is in the case of infant mortality. And I pose that question. I would pose it in a class. Yeah, I'm going to rush through this a bit and simply give you the answer, at least my answer. And I'm up here, you're not, so I get to give this answer. We care more about babies than we do mothers. We structured a system that cares more about babies than it does about mothers. And we've emphasized that over time. Now, if that's true, how bad are we at babies if you're going to have that kind of a disparity? But it's even worse in the case of mothers. So how do we do in international comparisons if we now have a reasonably reliable measure to use? This is how we compare to all the other OECD countries. This is silly, because this includes the Andorras and San Marinos and Luxembourgs of the world that have nobody actually living there. There's no babies born, that kind of thing. So let's do a more reasonable comparison. Countries with at least 300,000 births, wealthy countries with at least 300,000 births. And if we do that, and we compare them, then that's much fairer. And instead of being 35th or something, we're last. And decidedly last overall. But here's where the disparities piece comes in again. Because one of the implications, I've been presenting this stuff for years, and there's 2 responses that I get back in a lot of cases from clinicians who are defensive about it. One is that we do a better job of identifying cases than other countries. That's why we're doing worse. I don't think so. I just spent half an hour telling you how bad we are. But the other piece of that is they'll argue, well, we're more diverse than those countries are. And that's what the real problem is. And it's sort of an implied thing. It's about those minority mothers, right? We'd be doing fine if it wasn't for that. So, all right, let me give you your due. What if we just compared the rates for white mothers against all those other countries? Well, then, if we actually do that, instead of being last, we'd be last. And that's a really important consideration here, because it's both things, right? The disparities are profound and real, and we need to address those. But at the same time, there's systems issues here that are going on, and a presumably lower risk population is not doing well either. Okay, it gets a little worse. Let's look for a minute at women's death rates in general, because who doesn't want to look at that? It's a fun thing. This is from the death reports, the overall death reports. And the figure you see up there reports deaths, and what you see is female death rates over time consistently going down. But note the circled areas. In some of those cases now, they've started to go up. And it turns out the age groups that are going up are women of reproductive age. So I took the data and started pulling the data out to run it. And this is what you see. You see a pretty big jump in 2015 and 2016. And this is overall death rates by age. And the most profound increases are women 25 to 34, which in turn happens to be the largest birthing population. It's about 58% of all the births in the United States out of women in those age groups. So I continued to do the analysis on them. Here are the overall death rates of females 25 to 34 by race ethnicity over time. And note what you see. Overall, the all increases about 23% over time. Who knew that our death rates are increasing that much? Some people who are deep into it, but the general public has no sense of that at all, that overall death rates are increasing. When you break it down by race ethnicity, actually the death rates for black mothers are going up slower. Overall death, this isn't maternal mortality now, this overall death rates are going up much slower, but at a much higher base. Right? The rates are still significantly higher, but going up much more slowly. It's the rates for white women that are going up the fastest in all these groups, which leads to the great irony of this slide. This is one of the few times where disparities are actually going down. Now, they're not going down because of much we should be proud of. We all want disparities to go down. A little bit in this case. If you go back to 2005, the death rates for black females have been going down. Death rates for white females have been going up pretty rapidly, thereby decreasing the disparities. But that's not the way people usually think of how they want to decrease disparities, right? By raising white death rates is not usually the goal. If you look at causes of death, it sort of reaffirms that. And what jumps out in the upper right-hand corner is the big jump is in accidents, unintentional injuries. Now, that's not car accidents. It turns out most of those are coming from this category, poisoning and exposure to it's opioids, right? It's overdoses, right? But in there also is increases in intentional self-harm, homicide, chronic liver disease. These are public health problems, right? The clinical community is very much involved in public health, but the public health community itself needs to step up and get more involved. So is anyone discussing these increases? And by the way, male rates are increasing as well in the same age group. Male rates jumped by 26% in that same time. Yeah, I was. We put this out a while ago. Neil Shah and I put this out a while ago. And like most of the research I put out, disappeared without a wake. But we really need to be talking about this. We need to talk about this in a general sense of these increases that are happening. State of Massachusetts this is from a state report on opioid deaths, for pregnancy-associated opioid deaths. And these are by time period. And note in the postpartum period, the surge in substance-related deaths. But think about how often we drop mothers from the system. So I'm not going to read all of these, but these are the but I'm going to post these slides if people are interested. I'll post them. I give my stuff away. Why are things better? Now I have about 30 seconds to do the good news. Very much an academic talk. Oh, I have a whole minute. I just doubled my time. A couple things. All right, at least it dropped in this most recent year. Okay, I'm looking for hope here somewhere. In the update, it actually dropped a little bit, and that's random variation for the most part. But it didn't go up at the time that all the other death rates are going up, and I think maybe some of the efforts that are underway around the clinical improvements are having an impact. What you see here. If you look at the numbers across the bottom, these are causes of death over time. And what you see is declines in hemorrhage, hypertensive, infection, 2 types of embolisms, and anesthetic complications. In other words, in the areas controlled by clinicians, we're doing better. What's going up? Cardiomyopathy, cardiovascular conditions, cerebrovascular accidents. In conditions that are obviously related to clinical work, but often very much related to community work, they're going up. And other is going up as fast as almost anything, which encompasses mental health, violence, all the other issues. So the clinical side, we're doing a really good job. I think the AIM program, the establishment of perinatal quality collaboratives, the work coming out of California, I hate to admit it, is great and helping profoundly with that. This is just an example. Okay. Oh, good. They just extended my time. She says I can go till 4 o'clock. This is from the California Toolkit on addressing it, and I applaud. Again, I'm on the OB faculty. I love my clinical colleagues. They're doing. I think they're doing their part in this. I think the public health community needs to step up and get more engaged in all of this. And my students know I hate pie charts. I say, this is frequency distribution. Don't do it. It's silly. It doesn't convey that much information. And I put that stupid pie chart on my wall now to argue for public health involvement in dealing with maternal mortality. Because so many of the deaths are out of the period we most associate. And what the public health community has done around childbirth, for the most part, has said, we care about prenatal a little bit, we care about postpartum, and we'll leave the birth to the clinicians. Okay, if you're going to do that, then step up in the prenatal period and in the postpartum period to make sure we follow up. So what other kinds of things? Who can handle this? I think the review committees can handle it. I think perinatal quality collaboratives can handle it in terms of pulling together that side of this process. This is just more information on those. Again, some of you were on this. I know. I'm on it, and I know you're from there. The review committees, most of the states now have them. If they don't, they feel guilty about it because there's so much attention to it. I monitor this stuff, and state after state at least have to have a debate about it in their state legislature because of the national bill that was passed that I'll talk about in a minute. So this is a great resource and really, really helpful. For example, this is out of the Georgia Maternal Mortality Review Report. This is one of the things that you work on for Maria. What were the factors that contributed to this death, this maternal death? Note, these aren't precise categories. Understand, right? We struggle with these when we're in the committees. But 56% of patient and family, 9% systems of care, 7% facilities, 26% provider, 2% community. In other words, if only a third of all these pregnancy-related deaths involve provider or facility, what are we doing about the other 67%? How are we addressing those? We tend to do what we can do, right? We take the skills we have and we want to apply them to do good. That's why we're in this business. Public health people have to do their part. I think the clinical community has stepped up. There's still work to be done. There's still mistakes that are made, and that can be addressed. But this is a time to move beyond that. This came out of the Maternal Mortality Review report yesterday. And it's way too dense. And I always tell my students, never put that much content on the slide. I would highly recommend you get the report. You can download it very easily from the NCHS website. But notice what they talk about. The kinds of things they talk about as contributing factors. Access to clinical care, unstable housing, lack of or inadequate transportation, obesity and chronic conditions, health facilities, limited experience with obstetric emergencies. That's been the big focus of late, trying to address that. Lack of appropriate personnel, lack of guidelines. For patient and family, lack of understanding of warning signs, non-adherence to advice. From the system's perspective, inadequate receipt of care, lack of case coordination. We see that all the time. The biggest challenge we have, I think, when we're doing the mortality reviews is the cases, and these are the cases, I don't get the clinical cases, but the cases that arise where it's someone whose whole life has been struggling, right? That they died 7 months after they gave birth. That's after 12 years of addiction. And they may have gotten sober they made extraordinary, breathtaking efforts to change their lives during their pregnancy to protect their babies. And then, for completely understandable reasons, the Department of Children and Families will still take the baby away because their lives are pretty erratic, and the mother crashes and disappears. And the way we've structured our system almost encourages that, because if she was on Medicaid and she qualified for Medicaid only because she was pregnant, 60 days after that, the eligibility goes, and she's out of the system, and we've lost them to the system. And so when we're having these, and these guys are all here on it, when we're having this discussion, it's sort of like, they know I whine about this all the time. It's like, is it preventable? Well, geez, if we had like a real social system that took people in early and worked with people for their lives, and we took a life course approach, yes. In the conditions we have now, no. If we just look at it from the perspective of we have a contact with her when she's in the hospital, no. The other side is the policy challenge. Don't worry, this is it. We passed the Preventing Maternal Deaths Act of 2018. It wasn't easy to pass. I think it's really critical to understand what it did was fund the development of, essentially fund the development of maternal mortality review committees, provide funding to states that want to develop AIM programs and maternal review committees, which is great. My training, my PhD is in political science. I did legislative analysis for decades. I think of it as a policy perspective, and there's two ways to look at this. Either this is the beginning of a wedge that gets driven, and the strategy is you get your foot in, and then you incrementally increase support. And that's what this has to be. Because the other thing that happens, especially with maternal and child health issues, is we're treated symbolically. This was $25 million. That's like couch change in the federal budget. And the fear I have is that if we don't consistently work on advocacy, what's going to happen is they're going to say, we dealt with that issue last year. We just passed something on that. We don't have to deal with anything else. That's what we have to deal with. So here are the policy responses. President Trump even signed it. You can see how excited he is at having signed the Maternal Death Act. It's a big moment for him. The bill on the right is, I think, the stronger way to go. This is Senator Booker's bill and a whole bunch of other senators. People, as Alden noted, people are starting to get onto this. The value of this is it says we will extend Medicaid coverage out to a year instead of 60 days for pregnant women. How does that work? I love this chart. I use it all the time. There's going to be a study coming out in the next couple months that updates it, which will be great. But what does this say? Look at the teal line, the bottom line. That's the number of women who are uninsured. And this runs from before delivery to after delivery. And what you see is before they get pregnant, about 20%, this is pre-ACA, about 20% of mothers had no insurance. They get onto systems, mostly almost perfectly Medicaid systems, right? They're not getting onto private insurance. And by the time they give birth, at that time, about 10% weren't insured. That's pretty stunning in itself, by the way. And that number has come way down after ACA. But then, within 2 months, it's back up to 20%. How does that happen? This is how it happens. This is the poverty level requirements. And the national average is, for a family of 3, if you make more than 138% of the poverty level, you don't qualify for Medicaid. But if a woman's pregnant, that figure goes up to 205%. So the median number for all the states is 138 and 205. And if you look at the New England states, most of them are right in there. Right? They're right. Maine, okay. But the rest of the states are right in there. But look what happens in some of the other states. Texas is fine. It's 203% if you're pregnant. If you're not, if you make more than 18% of the poverty level, in other words, more than a whopping $3,700 a year, you don't qualify for Medicaid anymore. You're out of the system. So I believe in the wedge. I believe in starting and then building on it. I think we have to push for legislation that they're not going to do everything. They're not going to, Medicare for all may not happen. In waiting for that to happen, we make the argument, given the concern with maternal mortality, that we move in and we say, look, 12% of the women are dying from 42 days out to a year. Shouldn't we cover them for a year? Shouldn't we at least go that far to protect them? And then maybe, given the interest of maternal mortality, that can be the next step. And then we try to build on that, a step at a time. That incremental approach is how legislation happens. It involves compromises. We hate compromise because we think we know everything. But that's what's going to happen. So, finally, why are things better? Hey, 5 years ago, who was talking about maternal mortality? This wasn't a discussion at all. I know, Fifi was. But most people were not. There was not much discussion of that, and certainly not as a national issue. The clinical community has responded. I've talked about that. MMRCs are a big help and moving forward. And the public health community has started to deal with that, focusing more on social determinants than it has. I'm going to close with this. There is political will now. We usually don't have it. The media is thoroughly and totally engaged on this issue right now. ProPublica has done a spectacular series. It was their Pulitzer-type series. I think they thought they were going to get a Pulitzer. They got a finalist. They didn't get it. But on maternal mortality, I would highly recommend it to you. It's brilliantly done. This is the case of a CDC doctor in reproductive health who died. Really? She died after she had given birth. And the series documents in excruciating detail how all the cases that were missed. So, People want answers. What kind of answers? Since you asked, this is what I recommend. Using the MMRCs, I talked about that. Using linked data sets. See, Fifi, I told you I'd talk about linked data sets. Linked data sets to give you a bigger picture of what's happening to women over time. Listening to women about, if you want to have sustainable responses, you've got to listen to women. It can't be a bunch of policymakers, old white guy policymakers sitting around talking about what women need. You have to shut up and listen to women about what they need in doing this. And then get involved in advocacy efforts. In 3 days? March for Moms is in Washington. I would encourage people to get engaged in this and get engaged in efforts like that. If you want the slides, go to this website, birthbythenumbers.org. These are all the students who work with me on it, and over the years, they've all been helpful on it. And I post my stuff there. So if you're interested, go there. We're revising it. There's going to be a bunch of other resources that'll be started adding to it soon. It's not a requirement that you have a dog to join the group. So if you're interested, let me know. This is all volunteer effort, and the students do a terrific job in dealing with that. Thank you.